All right, this is Goku's last episode. Today, we're talking about colon cancer. Colon cancer / colorectal cancer. This is one of those things that comes up a lot just because colon cancer is the third most common cancer for men and women, or even if you combine everything, same thing, third. So it's important. The other interesting thing about colon cancer or colorectal cancer, I'll probably refer to it as either or during this conversation. But the common thing about it is that regardless if it's colorectal cancer, colon cancer, is that we have good screening, colonoscopies starting at age 45, and we have early treatment. This is one of the few cancers that if we are aggressive about screening, we can actually affect the number of people that are diagnosed with cancer. So that's why everyone always talks about colon cancer, colorectal cancer, screening at age 45. It used to be 50. Cologuard test. All of those are focused on catching polyps when they are dysplastic, not cancer, or tubular-villous adenoma. We'll talk about all those nomenclatures later on. But let's talk about colon cancer specifically. Colorectal cancer is cancer of the colon or rectum. Pretty simple, nothing crazy about the definition. Again, third most common cancer affecting men and women in the United States. The reason we do all of this is to prevent any of these symptoms that occur. All of these symptoms occur when you have a colorectal cancer or a large polyp. Before we get through the symptoms, let's talk about some of this anatomy first. Okay, so this is where we split lectures. If you're watching this and it says medical student lecture across the top or somewhere here down in the bottom, if it says medical student lecture, then this is the long version. This may not be the one you want to go see if you're a patient. Cecum. Cecum is the part of the colon where the appendix and the small intestine join in. And the small intestine comes in here. We'll talk about why that's important later with a resection. The ascending colon is going up. It's also referred to as the right colon. Hepatic flexure, the liver lives right here, so it covers this area. Transverse colon, which is the area where the majority of storage occurs for poop, is still called a transverse colon. It's always transverse because it goes across. Splenic flexure, spleen covers this area, is on the left side. The left colon, which is really just a transition between the transverse colon and sigmoid colon, which we'll talk about later, but it has the worst blood supply out of everything. Sigmoid colon, S-shaped, kind of goes around like an S and then connects up to the rectum. The other interesting anatomical fact about all of this is the sigmoid colon is a intra-abdominal organ versus the rest of this, with the exception of the transverse colon, is a retroperitoneal structure. So this has a peritoneal lining that it's attached to. This has a peritoneal lining that it's attached to, and so does the rectum. The descending colon or left and transverse colon do not. Again, we'll talk about that when we get to treatment. And then the rectum, and below Goku's thing is the anus. Notice this is not called colorectal anal cancer. This is really colon and rectal cancer because the anus is completely different. We'll talk about that at a later time. And the treatments for anal cancers are completely different than the treatments for colorectal cancer. One other small difference between colon cancer and rectal cancer is that rectal cancer traditionally involves radiation. Colon cancer does not. And it really has to do more with the location of the tumor and the anatomy of the organ than it does anything else. Rectum is fixed, it's always in the same place. Right colon, transverse colon, left colon, sigmoid. The sigmoid and the transverse are not fixed, so their position can vary a little bit, but the right and left are covered by small intestine. So you can't do radiation to these without going through other structures. So traditionally, we don't use radiation for colon cancer, we only use it for rectal cancer. Sorry, Goku. As far as the anatomy of a polyp, this is pretty much the sum up. You have normal mucosa that over time transitions into an adenoma. Once that adenoma grows bigger than the lining of the colon, it starts to develop dysplasia. Now, there are different types of adenomas. You have tubulous adenomas, tubulovillous adenomas, you have pedunculated polyps, pedunculated adenomatous polyps, you have different types of polyps, and I'll go through those at a later date, and I may just throw up some little slide that kind of shows you the transition, but you kind of want to think of it as a 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 is cancer. So there's a growth transition that goes on. The interesting thing is that 1 through 10 is a pretty good analogy, because from normal mucosa to an invasive cancer, it takes about 10 years. So the nice part about that is that we have plenty of time to catch it as a adenoma, a tubular adenoma, a tubulovillous adenoma, or a dysplastic lesion before it turns into cancer. So that's how we determine whether I need to see you in 2 years, 5 years, 10 years, because if you have an adenomatous polyp, I may want to see you in 2 years if you had a bunch of little small ones. If you had a big one, it may be 1 year, 5 years, or follow up in 6 months if it was dysplastic and we need to remove it. All of this anatomy kind of plays into your symptoms that we talked about over here. Hematochezia, blood in your stools, melena, dark tarry stools. This suggests an upper GI source or a right-sided cancer or lesion that's bleeding and getting mixed in with stool. Abdominal pain is usually a late sign, but it can happen. Iron deficiency anemia, or you're bleeding and it's not enough to drop your hemoglobin a lot, but it's enough to eat up so much iron in your system because your body's trying to replace it that it's hard to just give you a transfusion, give you iron. It's not that simple. So unexplained iron deficiency anemia. Bowel habits, if you start having loose stools, if you start having tarry stools, if you're a little more diarrhea than constipated than you normally are, those types of changes that are the changes that we see with bleeding from masses, simply because blood makes you poop more. It's as simple as that. In some instances, you'll have people that say, hey, I feel something hanging out my butt. Sometimes it's a hemorrhoid, sometimes it's not. So depending on their age, 45 years old and up, we kind of have to take that a little more serious because it may be a rectal cancer. Also, a late stage or a large abdominal wall mass is usually an intra-abdominal mass is growing out. That can be a late stage finding or a sign and symptom that you have a colorectal cancer. Because remember, breast is number 1, lung is number 2, colorectal is number 3. So common things being common, if you have an abdominal mass and you haven't had a screening colonoscopy, it very well could be a colon cancer. As far as diagnosing these, colonoscopy is number 1. CT scan is a good extra modality if we're talking about preoperative treatment or just looking because you had an abdominal mass, unexplained anemia, or abdominal pain. That's usually when CT scan comes into play. It also comes into play if you're trying to do a laparoscopic colon resection as opposed to an open colon resection, and we'll get to that when we start talking about treatment. One thing that we also need to address is Cologuard or guaiac stool cards. Guaiac stool cards, what that does is tells us whether or not you have bleeding in your stool. That doesn't tell us if it's from an ulcer in your stomach. It doesn't tell us if it's from a polyp. It doesn't tell us if it's from a cancer. But it's a good place to start. These are typically those cards that you get at your doctor's office, and they either put it in the card and send it off, or they'll mail them to your house sometimes depending on your insurance. And you'll just put a little stool sample on it, send it in, and they'll test it. What they're looking for is iron or stool that should not normally be there. Because it's mucosa, there's always a little blood, but it's a microscopic amount that you see in stool. Once you start seeing enough that can turn these tests positive, that's when you got to start thinking about maybe getting a colonoscopy. The other one is Cologuard. Cologuard is a nice test. What it does is it looks for dysplastic cells in your stool sample. But remember, the trick is once you get to dysplasia, you've already gone past a polyp. You've already gone past a tubulovillous adenoma, and you have some dysplasia. So a Cologuard is not a good test to just do that and never do anything else. You probably need to have at least a base screening colonoscopy And if you're negative from that point on, once every 10 years, using a Cologuard, if you have a strong family history to do screening in the meantime, is a reasonable option. Now we're going to talk about treatment of colorectal cancers. We're going to separate these out a little bit, and it's going to take a little time because there's one big difference between colon cancer and rectal cancer. With rectal cancer, you do preoperative chemotherapy, radiation, followed by surgery for a T2 lesion. For colon cancer, we traditionally don't do radiation unless you have metastatic disease, and we traditionally proceed with surgery followed by chemotherapy. The only time that gets switched is if we are doing this for metastatic disease, but we'll talk about that once we get into treatment. So first things first, once you've had a colonoscopy, you want to be able to localize the cancer. If you have a large tubulovillous adenoma with high-grade dysplasia or a early cancer on a stalk, you can sometimes remove them endoscopically. But the whole goal of doing a colonoscopy for colon cancer is to hopefully be able to remove the polyp before it turns into a cancer. If you have one that is too big to be removed, or it's on the right colon, because the right colon is much, much thinner than the transverse and the left colon, you would then have to proceed with an operation. Rectal cancers, sometimes we can do a transanal excision where we go in and remove a T1 or T2 rectal cancer lesion, even though it's cancer, and those patients do pretty well. T3, which is another stage, is about staging, and we'll talk about that later, for rectal cancer, that you have to proceed with traditional surgery. If you have a colon or rectal cancer and you've done your chemotherapy, radiation for rectal cancer, or you've just been diagnosed with a colon cancer, you then have to have it removed. There are about, who knows, many different combinations of this. It usually breaks down between open surgery and laparoscopic surgery. Laparoscopic surgery can include hand assist, so a hand assisted colectomy. You can do it with a robot. You can do it completely laparoscopically like I do. Combination of all four. Once you remove a cancer or a large polyp from someone, you also have to do a regional lymphadenectomy. Now, this is important because you don't want to go in and just take the tumor out and be done, because then if it comes back cancer, you have to go back and remove lymph nodes. When you're doing a laparoscopic or open colectomy, no matter how you do it, it's an anatomical dissection. What that means is you don't just take out the cecum, you take out the right colon. You don't just take out the little mass at the splenic flexure, you take out the whole left colon. If it's in somewhere in the sigmoid colon, you take out the sigmoid colon. If it splits the two, it's right between the right colon and the transverse colon, you have to decide, you have to decide from an anatomical standpoint what side of the middle colic artery it's on. If it's on the right side of the middle colic artery, you take the right colon. If it's on the left side of the middle colic artery, you take the left colon, even if it's in the transverse. So this is dictated by where the blood supply comes from, because we have to decide, we have to stage this person. Staging is tumor size, the next one is N, which is lymph node status, and the next one is metastatic disease. So every once in a while you'll see us go something like T1, N1, M0. So what that does, that's actually pretty uncommon. We'll call it a 3, T3. But that's how we stage tumors. And I'll give you a long list. No one memorizes it. You can memorize it. I've memorized it a couple times, but it always changes. So that pretty much we look at. But this you can find out sometimes. If you're doing endoscopic ultrasound, you have a good idea, but this one and this one, these first two, you find out doing surgery. So you have to do a regional lymphadenectomy when you're doing a resection, and we do it even if it's a large polyp, because we don't want to have to go back. Now, again, for a rectal cancer, this is a little different. For a colon cancer, it is truly a right colon, left colon, transverse colon, sigmoid colon. You're done. You're doing anastomosis. Right colon because you're removing part of the small intestine. You hook small intestine here up to transverse colon. So anything from here up, we don't have to do a colostomy, or the bag, as everybody likes to call it, unless it's absolutely necessary, dictated by something going on. And usually, if you're talking about colon cancer, a bag is temporary. For rectal cancer, it depends on how low it is. Rectal cancer, draw a straight line here. It divides into basically two areas. We call it the peritoneal reflection, but it's really right here. So anything below the peritoneal reflection is rectum. Once you get down here deep in the pelvis, the peritoneum, this is actually underneath the peritoneum and it's deep in your pelvis. So this part, if you have one, and we traditionally call this is 0 where the dentate line is, this is 10, and this is usually referred to as 20, but it can be like 16 to 20, 16 to 30, depends on how you look at it. 10 up, you can do what's called a laparoscopic or robotic assisted lower anterior resection. It's referred to as an LAR. We can go in, cut this out, hook it back up, not a big deal. Once you get in this 0 to 10 range, so you'll hear us talk about rectal cancer. It's 2 centimeters from the anal verge, 5 centimeters from the anal verge, 15 centimeters above the dentate line. Once you start getting into those measurements, that's telling us whether or not you're at risk for something called a APR. APR is an abdominal perineal resection. Abdominal perineal resection basically means that we have to take all of your anus out and your distal rectum because we can't get them back together. And the whole goal of treating colorectal cancer or all cancers is to try and get a negative margin. We would rather sacrifice your ability to have a normal bowel movement than leave tumor down here. We can sometimes, depending on if it's a woman, cut this down to 5 centimeters. So if you have one in here, we can stretch it out and get it. We can, once you give preoperative chemotherapy radiation, it frees it up a little bit. It's able to get it. So we have different techniques, but if you get 2 to 3 centimeters, there's a chance you may require an APR, abdominal perineal resection. What we used to do is do postoperative radiation. That postoperative radiation now is pretty much preoperatively done. Every once in a while, you have to do postoperative radiation depending on your stage. But again, that pretty much is for rectal cancer, not so much colon cancer. We can talk about APR more if you want to later on down the line. It's a complex surgery, but the main question patients ask when they have a rectal cancer is whether or not I'll have to have a bag. A lot of times your surgeon can't answer that until he's in the operating room, until she gets her hands in the pelvis and can say, hey, I can put this together or not. It depends on if you're a female and you've had a lot of kids, so you have a wide pelvis, that makes it easy. If you're a male and you have a very narrow pelvis and you're skinny, it makes it hard. If you have a big tumor, it's very difficult to get a negative margin. If you have a small tumor like a T3 tumor, then yes, you possibly could go down to 1 to 2 centimeters. But traditionally, if you are above 10, more than likely you're in the clear and you're not going to have an abdominal perineal resection, versus if you are less than 10, it is a possibility. The other thing we need to talk about is metastatic disease. 25%, and this is a crazy number, we've gotten it down, but about 25% of patients that present with iron deficiency anemia, anything like that, those symptoms that we talk about, present with metastatic disease from colorectal cancer. That's about as high of a number as I've seen in different series, but it's real. If you present with metastatic colorectal cancer, that's a different issue. With metastatic colorectal cancer, you have two issues. The disease has spread already to somewhere else in your body. So it's not just about getting local control. It's not just about removing the mass so that you can have normal continence, so you don't have to have a bag. It's about managing the systemic disease first. Now, let's say you come in and you have a lesion in the left lateral lobe of your liver and you have a 5 centimeter mass in your transverse colon. In that situation, sometimes we'll give chemotherapy first to see if you respond to the liver lesion, and if you do, go in, do the liver lesion resection at the same time as we do the colon resection. But let's say you have it in your liver, let's say it's in your lung as well at the same time. Removing the primary tumor is not necessary if it responds. One of my patients that I always talk about, he presented just like this. He underwent multiple treatments with chemotherapy, and we never removed his primary because it always responded every time he got treatment. He actually lived 5 years with metastatic colorectal cancer. So if you have metastatic disease, we may or may not just proceed in with an operation, especially if you have colon cancer. Otherwise, it's resection first for colon cancer, followed by postoperative treatment with rectal cancer, preoperative chemotherapy, radiation. Now, one small thing about rectal cancer, if you have a T1 or T2 lesion in your rectum that's low, sometimes we can go in and do what's called a transanal excision. That's where we remove that mass first, and then you may not require any other treatment. If you're a T2, you may end up having to do treatment. That also depends on staging and figuring out if it's a T1 or T2. Typically, it's done with an MRI that's dedicated or a endoscopic ultrasound. Again, different topic. We'll get into that later. Now, you've had your resection. If you've had it open, you have a big incision here. If you've had it laparoscopically, you have a couple of small holes and a lesion here and an incision in the midline or wherever. If you've had it done with a robot, you may have a couple of extra ports and you may have one semi-large incision in the midline versus if you've had it done with a hand-assisted port, a little larger incision. Regardless of all of that, the follow-up is the same. One of the things that plagues colorectal cancer surgery, and really even diverticulitis, if you're pulling colon out of the abdominal wall, you run the risk of wound infections. If you smoke, if you're diabetic, you're at higher risk for wound infection complications. So we always watch for that. There's some studies that talk about the incidence of hernias that you develop from colorectal cancer surgery in the midline is as high as 21%. It can be low as 5%, but it's still going to happen because, again, you're pulling poop out through your abdominal wall. The other thing that we always worry about is when we connect the colon to the small bowel or any type of connection, that connection has to heal. If that connection doesn't heal, you can leak. Traditionally, if you're going to leak, it's going to be around day 5 to 7. That's why most colorectal surgeons, general surgeons, anyone doing colon surgery has a patient follow up around day 5 to 7 to make sure that that anastomosis heals. If that anastomosis doesn't heal, then that sometimes requires antibiotics, sometimes requires a drain, and in certain situations can actually require a repeat surgery for a temporary colostomy. With regards to follow-up, otherwise, we're looking for colonic bleeding or any type of bleeding because sometimes you can have a polyp and an ulcer. We'll take out the polyp, even if you have cancer, but you're still anemic. So we still have to investigate that. So we always check for that. You can have bleeding in your stool 4 to 6 weeks after colon surgery, and that's normal, so nothing to worry about. Again, perforation is usually, if it's going to happen, it's day 5 to 7. So that's that magic time that you always have to watch for. Obstruction can occur if you have a hernia because small intestine or colon has got up in one of the incisions and blocked off, or if you have significant edema and you had a small anastomosis when they connected your colon together to the other section. You can have an obstruction, but usually not common for edema to cause an obstruction in colon or colorectal operations. You can develop an ileus, and that's usually what keeps most people in the hospital. But once you're passing gas, you're fine. Once you have a bowel movement, you're fine. Most of the gas that you pass after surgery is from swallowed air, not from food that you ate. So that's kind of how we know that the system works, because air is going from your mouth all the way out your butt. So we know that you pretty much can go home. Pain management, fluid management, usually done in that 0 to 5 day period when you're in the hospital. The length of time that you're in the hospital is determined by how fast the operation is done, how many comorbidities you have, as well as the type of operation. If you have it done laparoscopically, you can be in the hospital 2.5 days. If you're robotic, maybe 3 days, open 5 days. And again, varies patient to patient. The most important thing to get out of the hospital is early mobilization. Get your butt up and walk as soon as you can after surgery. The longer you stay in the bed, the longer you will be in the hospital. So this pretty much covers colorectal cancer, colon cancer, rectal cancer. This is a topic that we could talk for months on. There's so many nuances. There's so many different reasons that we decide to treat some people with this type of surgery, this one with another one. We do chemotherapy, radiation first, this one we don't. Very broad topic. But the important thing is to get to your doctor before you develop symptoms. The most important thing is to get screened. Right now, screening starts at 45, no longer 50. If you have a family history, 10 years before the person in your family was diagnosed with colorectal cancer. So again, you don't have to deal with any of this if you get screened at an appropriate time. Hope this covers everything. Like I said, as always, likes, Instagram, questions, DM me, all that other stuff. Follow the channel. We'll get you taken care of. Guys, take care.